is clearly a part of the national and international scene in investigations of and clinical trials in the area of prostate cancer. The title of his keynote address will be Global Challenges, Global Strategies in the area of prostate cancer. Ian is Professor-in-Chief of Urology in the Department of Surgery at the University of Texas Health Science Center at San Antonio. He's a clinical coordinator of the prostate cancer prevention trial, sponsored by the NIH, NCI, and principal investigator of the Southwest Oncology Group's adjuvant radiotherapy for prostate cancer, also from the NCI, and frankly on and on. There are multiple clinical trials for which he's served as the leader, and I'd like to welcome him to give his keynote address.
Thank you very much. It's nice to be here, and welcome to all of you who have come. And it's very fortunate that we have this is being taped and is being put in such a format so that it can be webcast and provided to other audiences. I don't know if those of you who realize it, or who are here, realize the quality of the speakers that you have, with one exception. The folks that are in the front row, and some of the folks in the back row, and some of the folks who will be here tomorrow are truly some extraordinary thinkers. Dr. Kramer, who's the editor-in-chief of the Journal of the National Cancer Institute, who is sitting up here in front as I get this thing going, said, I was saying, I will try to get this going here, so let's try this. Okay, don't go away, there we go. And I was saying that we have truly the intellectuals and thought leaders in here, and Dr. Kramer said something to the effect that there's only one of them, and that's Dr. Brawley in the back, who graduated from the University of Chicago, or something to that effect. But we're really, I think that you're going to find that you're going to have a spectrum of observations with regards to the key issues in prostate cancer, and it's a privilege and a pleasure to have a group of the nucleus of thought leaders in prostate cancer here today in San Antonio. So what I'm going to do is to try to set the stage. The nice thing about being a keynote address is that you can wander about and touch on high points, and I think that some of the things we'll talk about for the next 45 minutes or so will be many of the jumping off points that will be addressed by a number of the subsequent speakers. So I hope this will give you a little taste of what's to follow over the next 2 days. Prostate cancer, as we all know, is a disease of aging, or as I talk to my patients, it's not a disease of aging, it's a disease of maturation as we approach our midlife years. And as you can see, it turns out that if you look in a textbook of urology from 1926 in my office, prostate cancer occupies 1/2 a page in some 500 to 600 pages of a textbook. Probably half of that textbook has to deal with the urologic disease of importance at that time, which was gonococcal infections before the advent of antibiotics. And so prostate cancer was very much of an unusual disease process until perhaps the second half of the century, as public health improvements and other processes that have occurred that have allowed the adult male to live into his 50s, 60s, 70s, and afterwards. And so you can see here the incidence and the mortality of prostate cancer is directly related to age. Now, this is exacerbated in the U.S. population by the aging of the population itself and the demographics of the population. And the observation, as you can see here, this is the growth of the U.S. population over the age of 65, which is the primary at-risk population in terms of clinical prevalence of the disease. The most interesting observation that was made to me is that the fastest growing segment of the U.S. population is actually the centenarians, the individuals over the age of 100 years of age. And part of that has to do with many of you in the audience who manage the aging male. who get them to take their baby aspirin once a day, get them to exercise, eat properly, take care of these other diseases that can take their lives earlier on in life and put them at risk of developing prostate cancer. In the state of Texas, I'm going to give you some observations for Texas and for San Antonio as well. In the state of Texas, we have the same observation. This is the age-specific prostate cancer incidence in Texas. This is from this Texas Department of Health. And there are obvious, driving in this morning, there were some observations that were being made about the ethnic differences in disease processes. And there are huge, huge differences in the incidence rates and mortality rates of prostate cancer by different ethnic groups. And as you can see here, incidence rates in the state of Texas are relatively similar, albeit a little bit higher for African Americans than Anglos. And an interesting observation, one of the things that we're working on actually here through one of the NCI-sponsored trials is why is it that Hispanic men have about a 40% lower risk of developing and 40% lower risk of dying from prostate cancer than their Anglo or African American counterparts. Nevertheless, even for that Hispanic male, it remains the most common non-dermatologic malignancy. As you can see here, this is now the mortality difference. And remember that the Anglo and the African American had similar incidence rates, which point to some interesting detection observations that perhaps Anglos may avail themselves more commonly of early detection than do African Americans. But the most important endpoint for prostate cancer is not necessarily the detection of the disease, much less the disease's likelihood that it is the cause of death. And so mortality is the most important endpoint. And here are the age-adjusted mortality rates. This is in Texas, and they parallel virtually identically the US SEER data that African Americans have about a twofold increased risk of dying from prostate cancer than Caucasians, with Hispanics having that slightly lower risk. The reason of which is unclear, whether it's access to care, whether it's patterns, cultural patterns, dietary patterns. Certainly there may be some differences in genetic risk, and I know that we have some speakers who will be addressing that today that may explain some of these differences. Also, not only are we seeing differences in growth of populations, we're seeing dramatic shifts in the demographics of, for example, the state of Texas. And as you can see here, one of the most rapid growing groups of individuals in the state of Texas are Hispanics. And we have some data that suggests that Hispanics do not avail themselves of early detection of prostate cancer to the same extent that non-Hispanic Anglos do. And so it brings up some interesting early detection public health aspects in the possibilities of prevention in some groups that perhaps are not being addressed as much as we'd like. Even in Bexar County, and for those of you who are from outside of the state of Texas or outside San Antonio, Bexar County is our county. Bexar, it would be the proper pronunciation in Spanish, but we tend to slide over that. You can see here the growth, the rate of prostate cancer detection is significantly higher among Hispanics, surely because of the large fraction of the Hispanic population. And so, depending upon where you are in the United States, your focus on different ethnic impacts of prostate cancer may change. For example, the Asian population on the West Coast may have a rate that's quite similar to Hispanics, relatively lower, but if it constitutes a larger fraction of the population at risk in your region, it's obviously of important public health impact. So it remains a leading cause of cancer in males of all ethnic groups, and overall incidence is about 111 cases per 100,000 population, with 20 deaths per 100,000 population. And here you see the incidence rates, which is something that we'll be touching on during the discussions today, the disparity between incidence and mortality. In one sense, it's a good thing, because when we take care of patients with prostate cancer, we can tell them with some degree of assuredness that the diagnosis of prostate cancer does not mean that you go home, quit your job, and succumb to the disease process. That's not always the case. So the number of people who die of prostate cancer is a fraction of those diagnosed. The challenge is the flip side of that. And the challenge is trying to figure out which one of the individuals with prostate cancer needs treatment, who actually needs early detection. And that's some of the issues that will come up during our discussions. Now, coincident with this increased detection of prostate cancer, which we'll talk about in a second, has been a fall in the age of diagnosis of individuals with prostate cancer in the US. So that whereas it previously was a disease that was almost universally found in men over the age of 70 or certainly beyond the age of 60, the fall in age of diagnosis continues to this day. And it's not unusual to be seeing an individual with what we think is a biologically active prostate cancer in a man in their early 50s, if not a man in their early 40s, which changes the impact from a public health standpoint. So that you're looking at individuals previously, men in their early 70s with perhaps a 10 to 12 to 15-year life expectancy, and now we're looking at individuals who are in their early 50s, even in their late 40s, where the impact of the diagnosis of the disease, the impact of the treatment vis-a-vis the quality of life implications can be enormous for a significant period of time. And we're very fortunate to have some speakers today who will be addressing some of the quality of life endpoints or impacts on the diagnosis of the disease. Now, putting on your public health hat, there are other confounds with the management of or the diagnosis and the curiosity that is prostate cancer. And one of those has to do with your access to care. And in the state of Texas, we're not certainly any different than other states. There are variations in magnitude here, but it's an interesting observation that between the ages of 25 and 64 in the state of Texas, which is before the Medicare population kicks in, that some 25% of individuals are uninsured, which might almost certainly changes their health-seeking behaviors. And in the 19 to 24 age group, you see it's even greater than that. And this is the fraction of uninsured by age. You can see the vast majority of folks that are uninsured in the state of Texas are those individuals who are moving into the prostate cancer diagnosis age. And as you see here, the state of Texas is not significantly different from the United States. That no health coverage, perhaps a bit higher in this age range. Smoking behavior about the same, overweight perhaps a little bit higher, but in terms of health-seeking behavior, if measured by no mammograms in the past 2 years, it's about 30%. And so we have significant challenges, not only in knowing which ones of these health-seeking behaviors are important with regards to prostate cancer, but we have this hurdle to get over, and that is the availability of health care in this population. And as a result of this, we see dramatic differences in the applications of treatment by ethnicity. And these are data from Detroit and from the United States that look at the rates of application of radical prostatectomy among African American and Caucasian men. And this is among individuals who have the diagnosis of prostate cancer. You see some differences in the application of prostate cancer treatment. And Dr. Otis Brawley, in my recollection, was one of the authors of one of the earlier studies that looked at this issue a number of years ago, and he may be discussing this as well. And part of the differences in the application may have to do with access to care. Some of the differences may have to do with inherent risk, but some of the differences appear quite clearly to be due to some cultural differences in health-seeking behavior. A very nice study from Detroit looked at African American and Caucasian men and asked them some questions about their interest in early detection. And it's really very, very important. If you look at, for example, the likelihood of having insurance was higher among Caucasians, have a regular physician higher, ever had a rectal examination. Interestingly, Caucasians had a higher one than African Americans, putting off a rectal examination a bit higher, and talking to individuals about screening. So there are some differences that occur. Fortunately, there are some aspects of this that indicate that there is some differences in knowledge. For example, knowing that race is a risk for prostate cancer, African Americans had a greater knowledge of that, and yet it was only 1/2 of the individuals who were surveyed actually knew this. The other observation that I thought was key from this study was with the question of whether men with prostate cancer have a normal life. And slightly greater than 50% of men thought that men with a diagnosis of prostate cancer could return to their normal life. The flip side of that is that almost 50% of individuals in the general population were of the impression that if you were diagnosed with prostate cancer, that your life was significantly changed. And that's a real challenge for us to overcome. In terms of reasons for attending prostate cancer awareness, interesting observation that some 40% of these individuals strictly attended because it was free. Time for a checkup being 40%, and for symptoms perhaps 20%, showing significant differences. Finally, the reason why people got this information, and it's important for us as public health, wearing our public health hat, is that television and newspaper are obviously the key methods of getting out information into the community. So there are a number of challenges, and there are a number of questions, and I'm going to, obviously I'm not going to go into any great detail on this, but to perhaps set the stage for the rest of the discussions. With regards to early detection, and I think that we have some of the opinion leaders, unquestionably some of the opinion leaders, some of the very best opinion leaders in the United States and in fact worldwide are actually at this conference. There's a lot of promise with regards to early detection, but significant problems. And early detection for prostate cancer is not any different than any other types of tumors, and the issues are quite similar, but prostate cancer, because of many of the other issues, is infinitely more complex. The current approach is that we tend to apply screening to all men, and most tumors, or a substantial fraction of tumors, are treated. As a result, there's cost and overtreatment, morbidity, and it's kind of interesting with regards to what populations look at with regards to early detection aspects. And as you can see here, we're pretty good as a population about blood pressure checks. If you look at the digital rectal examination, perhaps only 30% of individuals in the United States are interested in having a digital rectal examination, with PSA actually being lower than that, perhaps 25%, suggesting that there's differences in applications of this. And just to perhaps set the stage of some of the issues, we have some real problems with the early detection of prostate cancer. One is this potential risk of overtreatment, and this is Weil-Sacker's data, suggesting that the background rate in the population of prostate cancer is substantial. These are data from Detroit, where Weil was working with the medical examiner and actually looking histologically at the prostates of individuals who died of trauma. And individuals in their 5th decade, as you see here, had some of a 40 to 45% risk of undiagnosed prostate cancer in their prostate. That's a scary thought. Individuals in their 40s. And obviously it goes up over time, so that your lifetime risk of actually harboring prostate cancer may be 70% or so. And then we have the risk of diagnosing disease that may be of no clinical consequence. On the left-hand side, you see this natural growth of prostate cancer from a microscopic focus to a point where you can detect it, to cancer spreading beyond the prostate, to the lymph nodes, to the bone, and ultimately dying of the disease. And so you have this band of potential detection where you can first detect it, and then you don't want to detect it beyond that band, if you will, because you can no longer cure it. We have 4 different types of patients. You have patient A who detects it, who develops it on the bottom, as you see, who over time of period of screening examinations is never found to have the disease. So that patient is not impacted by this. And patient B, who is destined to die of something else, who unfortunately is found to have prostate cancer and treated unnecessarily. Patient C is destined to die of his disease, as you can see, and is actually found to have the disease in that band of detection. So patient C benefits from it. Patient D, unfortunately, by the time his disease is diagnosed, which is the 3rd arrow, as you see there, it's already beyond the prostate. It was missed the year before, then it's found. That patient is diagnosed, treated, and still dies of a disease, and the treatment doesn't make a difference. So of those 4 hypothetical examples, only 1 patient potentially benefits from it. Now, on the other hand, we have these observations of what has happened with prostate cancer mortality and diagnosis since the advent of screening. These are data from the Department of Defense that have shown what has occurred since that time. And it's been this constant fall in the risk of metastatic disease. So when I began in the management of prostate cancer some 20, 25 years ago, about a third of all men found to have prostate cancer, a third to 40%, presented with metastatic disease. Now it's less than 5%. It's a rare person who presents de novo with metastatic disease. And we would like to think that that would indicate that there's a change in mortality, and it may or may not be related to prostate cancer screening. Here are the most recent data with regards to prostate cancer mortality, and you can see that as of 1999, based on SEER data, we've seen a 20% fall. But the real question is, what's it due to? Do we accept that it's due to the early detection, or do we accept that it's due to other changes? We've seen a fall in the, for example, the intake of dietary fat. We've seen a change in other behaviors that may affect mortality, and at this point in time, we have no idea whether that's due to early detection or not. Conversely, if you go to our sister country to the south, if you look at prostate cancer mortality there, it continues to increase. And we know that early detection is rarely practiced in Mexico. But whether or not this is due to the lack of early detection or other cultural changes, and we know that in many countries around the world, we're seeing an Americanization, for example, of the diet. So that in Japan, as the Japanese population changes their diet to make it a more westernized diet, is that perhaps the explanation for the changes? Now, we'd like to think that there are data from clinical trials that tell us what the right answer is with regards to prostate cancer screening. Just going to touch briefly on one of these trials conducted by Labrie in Quebec to tell you that unfortunately the data aren't there. And actually some of the individuals who were responsible for the trial that will probably give us the best information, the PLCO, are here and we'll be talking about it. But to show you that most of the data that we have are not terribly helpful. This was a screening trial conducted in Quebec. Some 50,000 individuals were randomized to be invited to prostate cancer screening or non-invited to screening. And as you can see here, based on the randomization, there were some people who chose to maintain that randomized arm, or some that chose the other, so that if they were invited to be screened. Interestingly enough, of the 30,000 and plus individuals who were invited to be screened, some 23,000 decided not to have it done. And of the individuals who were not invited to be screened, there was 1,000 or so that opted in, that still had their screening. And interestingly enough, if you look at the non-invited versus invited, the authors concluded that there was a 50% reduction in mortality. But if you actually look at the intent to treat analysis, actually when you look at the differences here, this is the intent to treat analysis, the invited versus the not invited, some 30,000 individuals invited versus some 15,000 individuals who are not invited. Even a urologist like I can tell that there's no difference. 30,140, 15,073. So we still don't know the right answers with regards to screening. Then the other issue that we have is biomarkers. At this point in time, early detection of prostate cancer is when it's rolled out into the community, and this natural experiment of early detection occurs with a rectal examination, which was first described shortly after the turn of the century by Hugh Young at Hopkins, who was actually a San Antonio native. It's a very interesting story. He fell into the San Antonio River when he was a young child. His mother, if you can believe somebody at risk falling into the San Antonio River, now you can stand up and walk around it, and even if you're 3 feet tall. But he fell into the river. His mother dove in to save him, saved his life in the process, and there's a window in the cathedral downtown that his father gave to the cathedral in recognition of his mother's saving Hugh Young's life. Hugh Young went on to become really the founder of urology for the United States, and founded the Brady Institute at Johns Hopkins. And he was the first person to suggest that rectal examination could detect prostate cancer early. We've subsequently found that that's clearly not the case, and that rectal examination by itself finds prostate cancer when about 2/3 of the individuals already have disease outside the prostate. So in the late 1970s with the identification of a unique protein, relatively unique protein, to the ejaculate. It's prostate-specific antigen. It's a kallikrein, member of the human kallikrein family that actually lyses the coagulum, the seminal coagulum, and leaks into the prostate. In individuals with metastatic prostate cancer, for example, have very high levels. It appears to be a useful screening tool for prostate cancer. And so what has happened is that it's been rolled out as the early detection method of choice. The challenge with it is that a lot of people with elevated PSA don't have prostate cancer, and a lot of people with a normal PSA do have prostate cancer. And worse than that is it behaves differently in different groups. These are some data from our own institution that show the performance of PSA by different ethnicity, as well as the evidence that biopsies can be positive, which are the black lines that you see on the top, even with normal levels of PSA. And with very high levels of PSA, even in those individuals, you may not have a prostate cancer the cause. Here among Hispanics is the performance, and here's the performance in African Americans, suggesting a real challenge that there are a lot of people with normal levels of PSA who are African American who have prostate cancer, very much of a challenge. And here are what's called a receiver operating characteristic curves of PSA by different ethnicity. Ideally, and I'm not going to tell you exactly, you don't need to know how a receiver operating characteristic curve works, but if you have a quarter in your pocket and an individual comes to see you and you're trying to tell them whether they should be tested for a disease, if you flip that quarter, that's about what you get with that 45-degree line there. And so anything that moves the line up and to the left improves the performance of the test. And a test that tells every single person that has cancer it's positive, and every single person that you know doesn't have cancer is negative, would be a curve that goes directly up to that one and directly across. Now, no test is that good, but we'd like the test to be as close to that as possible. And the interesting observation is we'd like to think that the test performs the same in different ethnic groups. And you can see there, clearly it doesn't. So we have a test that misses some prostate cancers, test that tells a lot of people they have prostate cancer when they don't have it, and then a test that performs differently in different ethnic groups. So we have serious problems. Now there are potential solutions on the horizon. There are new forms of PSA. There is a type of a truncated PSA called BPSA that comes from the adenomatous part of the prostate, and another kind of PSA that comes predominantly from the peripheral zone of the prostate that's called PPSA. And it appears that they have different configurations, they're cleaved in different locations, and they have a different number of amino acids. And we think that this is the way that PSA may actually be formed and be created in different isoforms by different states, such that the prostate luminal cell, as you see there, releases the PPSA, and if you have cancer that's creating it, it goes directly into the circulation as a PPSA. If you have benign disease, it gets released as a benign PSA, and then ultimately the PSA goes into the seminal plasma. So that we have some ideas that there may be differences in the type of PSA that will help us in the detection. And if you look at the specificity for PPSA, free PSA compared to PPSA, in this maintaining a 75% sensitivity, you can see that there may be some improvements in it. But specificity is extremely important to us, because specificity means that in a population of 100 individuals who come to see you, you'd like to be able to tell those 100 individuals who don't have prostate cancer, you'd like to be able to tell them they don't have it by virtue of the PSA test. Even with this kind of an advance, of those 100 people that you know for sure don't have prostate cancer, even with this advance, 25% will be told that they are at risk. So what's the solution to this early detection crisis, if you will? Well, obviously the right answer is a clinical trial, and the prostate, lung, colorectal, ovarian clinical trial is doing just that. And it's male and females, but of the cohort, some 74,000 or so individuals, males, have been randomized to screening or the usual clinical care. And there's a parallel trial in Europe conducted out of Rotterdam and a number of sites, and we're expecting the results in a number of years. This trial should provide us a better insight as to the effectiveness of early detection. But even so, we're still relying upon an inadequate screening test because PSA is not perfect. It does differently in different groups. It does probably differently in different ages. It tells some people that have the disease who don't have it, misses the disease in some. And so what we'd like to have is an ideal screening test so that men without the disease, the test is negative, and men with the disease, it's positive. And perhaps better than that, in men with disease that is indolent, if we had that crystal ball that would tell us that you'll never have problems from your prostate cancer, we want that test to be negative. In individuals that have biologically significant disease, we like the test to be positive. And there may be even better than that, so that we have men at low lifetime risk of prostate cancer. Perhaps at the age you turn 35, you have a blood test. And it says, don't ever go see a urologist again. Don't ever get tested. And then men with a higher lifetime risk, perhaps the test so indicates that, and if the disease is currently present, it's positive. If the disease is not present, it's negative. So you have this kind of a two-step testing process. And this is a way some of the visionaries are thinking about the way that we will be approaching that. And one of those visionaries is here with us today. It's Sudhir Srivastava, who's the program officer for the Early Detection Research Network, which is a project of the National Cancer Institute. And you can actually go online and look at some of the research that's ongoing. And it's a group of a number of centers that are working together to identify better early detection tests. There are two laboratories that are called biomarker validation laboratories. There are biomarker development laboratories that are taking new clues for the early detection of cancer, not just prostate cancer, but breast, pancreas, ovarian, lung, colorectal, and taking these new concepts, validating them, and then going to these clinical and epidemiologic centers, one of which is here in San Antonio, the other prostate one is at Johns Hopkins, to take these tests forward to see where we're going. And here are all of the institutions, as you can see, from around the United States. Texas is very fortunate to have 4 of these institutions so that we take promising directions in the preclinical laboratory, ultimately validating these tests. Rather than rolling out new diagnostic tests, screening tests early, we validate them and then take them out and prove that they actually work in the community. And one of the things I think Dr. Srivastava is going to be talking about is a very fascinating new approach, which is called protein profiling. And you may be aware of a recent paper in the Lancet on the subject of ovarian cancer out of Lance Leota's group and David Fishman's group that identified a pattern of protein expression among women with ovarian cancer that was absent in women without ovarian cancer that had extremely high performance characteristics, very high sensitivity, very high specificity, but it's a very much of a challenging test to validate. Here's an example of this exact data from the Eastern Virginia Medical School, which is one of the participants in the Early Detection Research Network. And this is how CELD is actually printed out, how you see the differences. You have these protein peaks, if you will. Each one of those blips up is a individual protein mass in the serum. And the top 6 lines, as you see going across, are normals. The bottom 6 are individuals with prostate cancer. In that red box, you see that there is a protein that is expressed in normal individuals that's basically absent in those with prostate cancer. And in the blue line, you see the peak in the individuals with prostate cancer that's absent in the normals. And now the obvious question that some of our urology colleagues would ask me is, well, is that peak in the blue, is it PSA? It's not. Interesting. So there are a number of very, very exciting new opportunities in terms of early detection, the results of which will be a continuing evolving area. Prevention of prostate cancer is a fascinating, in fact, one of the big problems with prevention of prostate cancer is there are too many opportunities. That's just a small list from diet, retinoids, isoflavonoids, COX-2 inhibitors, hormonal prevention, selenium, alpha tocopherol, bunch of these. But why can we prevent, why do we even think about preventing prostate cancer? Well, the reason for it is prostate cancer is a disease of mature individuals. I won't say older individuals, mature individuals. And if you can imagine, if we could not necessarily prevent prostate cancer, but delay its appearance, the average years of life lost from prostate cancer the last time it was looked at was about 9 years. As opposed to childhood malignancies or testis cancer, the likelihood you could prevent that, you'd have to prevent it for decades. Prostate cancer, if you delay it by a decade, the mortality rate from the disease would drop substantially. And we also know that this process occurs over many years. Remember, I showed you the slide that some 40% of individuals in their 40s have prostate cancer. So we have the opportunity to intervene early when the normal prostate is in the process of transforming itself to this putative pre-malignant lesion called prostatic intraepithelial neoplasia, to disease that invades the stroma of the prostate, to multifocal disease, to spread of the disease outside the gland. This probably occurs over a period of 30 to 40 years. So we have many, many opportunities to intervene. One of these might be through dietary fat. Epidemiologic studies show time and time again that dietary fat plays a role. And if you actually eat a lot of animal fat, it may increase your risk. How it actually does so, as you can see here, there are any number of mechanisms that may be the impact, maybe through a mechanism of inflammation through the arachidonic acid cycle that leads to the development of prostaglandins and isotrienones that lead to the greater risk of prostate cancer, or it could be a hormonal impact. We know that there's some data that those of us guys in the room here, if we go out and eat a diet that's high in animal fat, there's some suggestion that our excretion of androgens goes up. Our serum androgens go up, and if we switch to a vegetarian Asian diet, it drops. So it could be through a hormonal influence. We don't really know. Preclinical data suggests that that's the case, where if you take a diet restriction, growth on prostate cancer tends to be affected. And a fat restriction, here you see the normal growth of prostate cancer with ad lib, as opposed to fat restriction, which is the green line. You can see that the growth of existing prostate cancer is inhibited by an isocaloric diet with reduced fat. Interestingly enough, which it kind of talks to the a problem that we're having in the United States in terms of caloric intake and obesity, even more effective in terms of growth of a prostate cancer in an animal model, even more effective is caloric restriction. And so there's any number of examples of the possibilities of this. And certainly the epidemiologic data suggests that it might be effective. If you look at this graph here on the y-axis is the age-adjusted risk of dying from prostate cancer. Not detection, but death of prostate cancer. On the y-axis is your dietary fat intake. Each one of those dots is a country. You look up at the US at the top right, we have a lot of dietary fat. Our mortality rate is quite high. Parallels Northern Europe, parallels North America. Conversely, if you look at the dietary fat intake in Asia, very low numbers and very low risk of dying from prostate cancer. Now, the simplistic approach to this says, well, obviously diet's the answer. Not necessarily the case, because you might say what component of the diet plays a role in those Asian countries. Is it perhaps the intake of soy with the weak estrogens that are associated with that, or is it a genetic difference that's driving this difference as well? Another possible opportunity for prevention of prostate cancer is in the cyclooxygenase 1 and 2 system. COX-1 and COX-2 are the enzymes that you block when you take an aspirin. You block both of them with a Motrin as well, and now we have COX-2, specific COX-2 inhibitors that block only the inflammatory components of this system. Interestingly enough, if you look at where COX-1 and COX-2 are expressed, the organ with the highest expression is in the prostate, even more so in the lung, small intestine, and in the colon, much lower. And we do know that for the prevention of colon cancer in individuals with the FAP gene, that there is a quite significant impact with individuals with familial adenoma polyposis who have a very high risk of developing colon cancer, that COX-2 inhibition seems to be quite effective in delaying that. There are epidemiologic studies that suggest that the use of COX-1 and COX-2 inhibitors, this is a study from Auckland, that suggests that there is a significant reduction in the risk of prostate cancer with cyclooxygenase inhibition. So there may be opportunities for that, and there's a Southwest Oncology group trial that's currently under development that's looking at the issue of whether or not rofecoxib, which is Vioxx, which is one of the 2 existing COX-2 inhibitors that's currently approved, can reduce the risk of progression to prostate cancer. Now, there are two very large trials that are ongoing, and I'll talk about these in a second, but there's a huge global interest and emphasis on the prevention of prostate cancer. One of these is SELECT, which is, and I'm going to leave this trial for the prevention trial, for the prevention talk that's coming up a little later on today. But the current one that is in its last 2 years of study is the prostate cancer prevention trial that's looking at the issue of whether finasteride, which is a 5-alpha reductase inhibitor, can reduce the risk of prostate cancer. And this trial we'll be talking about in a second. We'll have results within the next year and a half. So in terms of global strategies, we've emphasized a lot here just in the last half an hour or so, the early detection issues, the ethnic differences issues, and we don't know where we're going with early detection. We've seen a fall in mortality, but we're not sure if it's due to early detection. We have the prevention opportunity, but practically speaking, what we're faced with today in the United States, practically speaking, is two things. One, from a clinical standpoint, we're faced with individuals diagnosed with localized prostate cancer and individuals who progress to advanced disease or present with advanced disease. And we have huge problems and huge opportunities to improve the management of these patients because we don't know the right management for any of these. With regards to localized disease, there are lots of different treatment options. Are there any distinct options that are distinctly superior? And ideally, what you'd like to know is you'd like to have some kind of thumbprint of that tumor, or crystal ball, if you will, so that when you're looking at an individual patient, you can say, for Mr. Jones, there is one best treatment for you. Because we know that prostate cancers are all different. And then, based upon that, because there are pros and cons of each one and various impacts on quality of life, how does that individual patient integrate the quality of life implications in his treatment decision making? We know a little bit about the natural history of prostate cancer, but it's imperfect. Because remember I showed you the incidence rates are much higher than the mortality rates. So the question is, do we have to treat the disease? Gunnar Aus from Germany looked at this with some 514 individuals and looked at the survival. So we found that by stage, if you look at early diagnosed prostate cancer, there was a relatively significant good long-term survival. Grade seems to play an important impact as well. That if you have a higher grade disease, your risk of dying from prostate cancer left untreated was substantially greater. The catch is that with early diagnosis, the vast majority of individuals in the United States diagnosed are that middle curve, which are intermediate level data. And I'm going to touch briefly on a subject that was brought up by Dr. Katz earlier, is the most recent information, which a lot of folks will spin the information from the Scandinavian trial in one direction and a lot of folks in another direction. This is a very interesting study. I encourage you to read it from New England Journal from 2 weeks ago. I believe it was published a week ago last Thursday. This was a trial that was begun in Scandinavia that took advantage of the opportunity for the current practice of prostate cancer management in Scandinavia at the time, which was that the vast majority of people in Scandinavia diagnosed with localized prostate cancer were left untreated. And the investigators there said, we have a unique opportunity to address the impact of treatment for localized disease. And some 348 individuals treated with radical prostatectomy, and some 347 were randomized to observation, and they were followed for 3 different endpoints. And it's an interesting group. It's not the typical group of patients that we see in the United States. As you can see here, the majority of these individuals were T2. Some 3/4 were T2, which means you could feel the disease. That's not the kind of people we see in the United States. And because of that, it's going to be challenging to take those data from Scandinavia and apply them in the United States. Additionally, the Gleason score, the majority of individuals with Gleason scores had Gleason scores less than 8. Which is a moderately or well-differentiated tumor. Some 13% had Gleason's 2 through 4, which is a very unusual stage in the United States. And I'm just going to skip through. The bottom line is a very interesting observation. Some of the newspapers and media outlets took these data and said, obviously on the basis of this, prostate cancer should be treated with radical prostatectomy, because that bottom curve you see there was the risk, was the disease-specific survival treated with radical prostatectomy. The top curve, this is the risk of dying of prostate cancer, was watchful waiting. Interestingly enough, though, when you looked at the same data, the overall survival was identical. The confounding issue to this was that this was reported with 8-year follow-up, is the difference in metastatic disease-free survival. The top curve is the watchful waiting risk of developing metastatic disease, which is about 25% or so. The bottom curve is the radical prostatectomy risk of developing metastatic disease, about 14%. So here we have some very, very confusing results. On one hand, it appears in metastatic disease, if you develop metastatic disease, your median survival is 30 months. So on one hand, we have a randomized clinical trial that says if you have prostate cancer, treatment reduces your risk from dying from the disease. On the flip side, it also shows that treatment for the disease has no impact on how long you live. So you can see the challenges that we have. And the way that we're approaching this in the United States is there is a parallel study ongoing. It's actually reached its accrual goal, called PIVOT, the Prostate Intervention versus Observation trial, randomizing individuals to radical prostatectomy or observation. It's about 1,000 patients or so that are being followed, and this trial is ongoing in the United States and will give us a better idea as to the impact of treatment in the U.S. Adjuvant therapy for patients at high risk of disease. We do know that some 1975, Bernie Fisher conducted and published a trial on the impact of adjuvant therapy for high-risk individuals with breast cancer. Prostate cancer is some 25 to 30 years behind this, probably 35 years behind our breast cancer colleagues. And the way that we're actually approaching that in the United States is we have some evidence that mitoxantrone has a role in prostate cancer treatment. And this is a study that actually from England that took individuals with T3, T4 prostate cancer, randomized them to hormones alone or hormones with 4 cycles of mitoxantrone, and these are the results. As you can see here, with hormone treatment alone, there was an inferior response rate to mitoxantrone and hormones, and more intriguingly, there was a double improvement in the median survival with the addition of chemotherapy, which changes our entire approach to where we think about prostate cancer, because traditionally, individuals who treat the disease traditionally don't think about giving patients adjuvant chemotherapy, and in fact, it's very much of a challenge if you have an individual at high risk for progression after localized treatment. It's a challenge to actually give that individual chemotherapy in terms of payer reimbursement for these patients. Just want to touch finally on some very interesting observations with metastatic disease. There's a huge collaboration going on in San Antonio with regards to the management of metastatic disease. The Institute for Drug Development, the San Antonio Cancer Institute, the University of Texas Health Science Center, and this effort here is a microcosm of the efforts with metastatic disease around the United States. Why metastatic disease? These are the most recent survival data for what happens if you have metastatic disease. Prostate cancer, once metastatic, median survival 30 months. Even for individuals with the lowest PSA at diagnosis, median survival under 4 years. Unacceptable, and we're not improving substantially on the management of metastatic disease, at least from our clinical trials, since the advent of the treatment some 50 years ago. And Sue Naylor is going to be talking about this briefly, but I'm just going to mention to you that Sue has identified some very interesting targets on the long arm of the 18 chromosome that seem to impact on the risk of developing metastases. And I'm just going to tickle your interest by showing you this slide. I think she's going to go into greater detail that actually may reduce the risk of developing metastatic disease. We have a group here in San Antonio who also have a reliable model, animal model, for the development of bone metastases. And in fact, in the middle metastasis that you see there is a very unusual item that we're in the process of moving forward, is the development of a blastic bone metastasis in an animal model. And perhaps the most intriguing thing that I'd like to close with is that these efforts in metastatic disease are paying off for patients, unequivocally. This is the Shionogi tumor model, and this will just give you a little bit of interest in where we're going in the management of prostate cancer. Shionogi tumor model is a mammary cancer model, but it parallels substantially the growth of prostate cancer. And you can see here that castration has an important effect on the disease. The beginning of that curve on the left, you see the growth of the tumor, and it's androgen sensitive, androgen responsive, just like prostate cancer is. And once you castrate the animal, you see a reduction in the volume of the disease. But just like prostate cancer, over time it becomes androgen unresponsive, as we see in patients with metastatic disease. The disease recurs, it's no longer responsive, the patient dies of the disease. As you can see from the blots up at the top, you can see that after castration, you get upregulation of a gene called BCL2. And BCL2 is an anti-apoptotic gene and protein. And what it does is it prevents the cells from responding to chemotherapy as one of the causes. So that when you castrate an individual, either medically or surgically, who has prostate cancer, you see upregulation of BCL2. So is it any surprise that when you treat that individual with a taxane, it doesn't respond? We have a bone metastasis model that shows that the same effect. So what we have, and I'm going to skip forward, what we have in San Antonio is we're testing a very interesting compound called G3139. It's an antisense oligonucleotide to the mRNA product of BCL2. And what it does is it specifically binds with the product, so shuts off the protein production of the BCL2 gene. And what we do in these individuals with metastatic hormone refractory prostate cancer is we treat them preliminarily with the antisense compound, effectively turning off the BCL2 product, and then begin taxane treatment. And here is an illustrative example of an individual with metastatic prostate cancer. On the left, you see bulky adenopathy. You see percutaneous nephrostomy tubes because the individual has obstructed kidneys from a ureteral obstruction. And then after treatment on the right-hand side, you can see it's gone. So many advances in the management of metastatic prostate cancer. So vision, global challenges, lots of them. And perhaps one of our long-term goals in all of this is something like this. And you see the paradigm of prostate cancer progression from the normal gland to prostatic intraepithelial neoplasia to invasive disease to nodal positive disease to the positive bone scan. Perhaps in the individual with normal disease, the way we're going is risk assessment to determine who has the high probability of developing prostate cancer. And then, either before or as we begin to see some of the changes, apply individual specific prevention strategies that may be different from me, between me and someone else here in the room. Individualized treatment strategies. Monitor these with a biomarker assay that detects not prostate cancer, but detects biologically significant disease, the disease that is of concern to the individual in his lifetime. As necessary, treat for cure. And if an individual escapes all of these multiple barriers, the prevention, the early detection, the treatment, ultimately develops metastatic disease, treat the disease as it progresses to treat it for cure at that point in time. So in summary, I'd like to tell you that it's a fascinating time to be in prostate cancer management. Prevention, early detection, science is moving forward, and we have many opportunities. And I think that perhaps I gave you a little bit of an overview of some of the very interesting observations that are going to be made by our colleagues who are with us today. And thank you all for being here.